Hi to you all. Welcome to Northside General Surgery Program. I hope you guys are enjoying your general surgery rotation. I hope you guys are learning a lot and be prepared to learn more. Um, this is Ali, one of the general surgery residents, PGY3. I'll be talking about fluids and electrolytes in surgical patients. This is a very high yield topic. From the past, from the discussion that I had with students, they probably get one or two questions on the shelf. And of course it's brought up during the rounds and during the comp and during your CK as well too. So let's get started. So this particular slide is not very high yield. There's some numbers that you need to know. You won't be asked questions. This slides will give you a better understanding or a concept of what fluid regarding fluid management in surgical patients. So some of the things that you should know: 50 to 60% of the total body weight is water. Two-thirds of that water, and it says at the bottom, two-thirds of that water in ICF. So that's the largest, and in ICF, the largest proportion is actually in the skeletal muscle mass. Um, Total body water is divided into three functional fluid compartments. One thing that you should know: the total body water decreases with age, and it's the highest in newborns. Lean tissue such as muscles and solid organs, which is seen in males compared to females, um, those people will have a higher water content. The lowest percentages of the total body water in females, and the reason for that is because they have a higher percentage of adipose tissue. So that's basically it for this slide. So let's move on to the next slide. This will just give you an idea. It's a table that gives you an idea of what to remember. Again, plasma has 5% total body water, and you see most of the percentages goes to the intercellular volume, which is 40%. Okay. Um, let's move on to the next one. Composition of a fluid compartment. So ECF, one thing to remember is sodium is the principal cation. And along with the principal cation, you have some principal anion, which is chloride and bicarbonate. ICF, the principal cation in that one is potassium. Magnesium is another one, phosphate and sulfate. Um, so three key concepts that you have to know. It's basically cell membrane permeability. So you have to know water passes freely. You have to know osmolality, and that's like property of particles in a solution. NaCl dissociates to two osmotically active ions. One is Na and one is chloride. One thing that I would know from this slide is this um, formula. So osmolality. Sometimes you send it for labs and they give you the osmolality, but sometimes it takes a long time, so you have to calculate yourself what the osmolality is. So the way you calculate that is that you have the sodium, you have the BUN, and you have the glucose from the BMP. So you can see the 2 times the Na plus the BUN divided by 2.8. So the way I would remember this is 2.8 is a smaller number and it goes with a smaller word. So BUN divided by 2.8. Glucose is a longer number. It goes over the larger number as well too. Okay, so that's what I would remember from this slide. Body fluid changes. So changes in body fluid volume and electrolyte composition occur pre-op, intra-op, and post-op. That's the important part. So when you see a lot of patients, you have to consider their fluid changes pre-op as well as intra-op and post-op. So if you have a patient who is preoperatively fluid deficit, then you'll have a problem intra-op and post-op. So you have to consider that as well, and how much resuscitation you need to do intra-op and post-op. Some of the numbers that you should know: daily water losses. So 800 to 1200 cc in urine, you lose 250 cc in stool, and 600 in sensible losses. So we talk about insensible losses. Some of the numbers that you should know: skin has about 75%, and then lungs has about 25%, and that also can increase in fever, hypermetabolism, and hyperventilation. Um, Another number that you should remember is the minimum amount of urine output that needs to be recorded in a patient is usually 800 cc as well. Let's go on to the next one. So disturbances in fluid balances. This is pretty important. The reason is that because you should be aware of some of the signs and physical examination when you see a patient. Many times when you are taking care of, which we will talk about down the road, about hyponatremia, you have to determine the volume deficit, and that kind of gives you an idea of what can be the cause of their hyponatremia. So acute volume deficit, you can see some signs of CNS, cardiovascular. So medimentation will be affected. The cardiovascular meaning that they can become tachycardic, hypotensive. Somebody who's chronically volume deficit, you have seen skin turgor, decrease in skin turgor, and sunken eyes. Some of the labs that you send. So the most common cause of deficit, before we go over the labs, the most common cause of deficit in surgical patients is usually from nasogastric tube. They have vomiting, diarrhea, or what sometimes it's seen mostly in surgical patients, the intracutaneous fistula. Another one would be somebody who has an ileostomy. Not colostomy but ileostomy, since you don't have the reabsorption of fluid in the colon, you be putting out a lot of fluid. So a lot of these patients come in with dehydration and volume deficits if they're not keeping their fluid balances up. Another one would be sequestration secondary to soft tissue injury. A lot of fluid can be hidden in the soft tissue after an injury that could cause a volume deficit as well. So some of the labs that we send, elevated BUN we'll look at, and there's always a ratio that we look at, and we'll go over that. You look at the urine osm, so somebody who comes in with hyponatremia, you send some labs, and those include some urine studies. You send the urine osm, and that's usually elevated or greater than serum osm. Then you'll be sending a urine sodium, which will be less than 20 between acute volume deficits, and the reason is because the kidneys will work overtime to reabsorb some of the water. Um, so we talked about this. Some of the signs, again, symptoms of volume disturbances. So generalized, you have weight loss and volume deficits. Also, on the other side, you can talk about the volume excess too. You'll have many times you'll have volume excess in surgical patients too. So they talk about weight gain. If you have this, an example of a pancreatitis patient where you put them on high volume of fluids because you try to resuscitate and you keep them MPO. You can put 200 cc of an hour of fluids where they urinate a lot, and you have them on that much fluid for 24 to 48 hours until the pain is resolved or improved before you start them on a diet. So they talk about volume excess as well, weight gain, peripheral edema, um, distended neck veins. We talk about volume deficits causing oliguria, azotemia. Another thing would be GI, which we see a lot, ileus. We see a lot of ileus patient versus bowel obstruction. We get consulted on these type of cases. We have to deal with ileus a lot of times, and we always ask ourselves, what can cause the ileus? Volume deficits, somebody who's dehydrated, somebody who has gastroenteritis, that have multiple diarrhea, and then the bowels go to sleep. So that can cause an ileus as well too. Next slide. So some of the things that you should know, types of IV fluid. So I would suggest grab a resident when you're on north side, grab a resident and have them show you the two bags of NS and LR, and you compare the back of those two fluids, and you get a better understanding of what we're talking about right now. So types of IV fluids, you have crystalloids, which has sodiums, and the sodium is a major osmotically active particle, and it's isotonic. When do we prefer? So this is a question that we've been asked before, and you probably will be asked during the rounds or you're on your shelf. Is when do we prefer 0.9 NS NaCl over LR? So you guys can tell me when you see me around. So that's homework for you guys, and you probably will know it by the end of this presentation. Some of the hypotonic fluids that we use: D5 water, half normal saline, which is 0.45. So just something that you should remember when you're resuscitating somebody. The difference of understanding kind of makes a difference, because when you have medicine team resuscitating someone with IV fluids, they do it differently than the surgical patient. One thing that they usually forget to understand is that 25% of the total volume infused, let's say you give somebody 1000 cc, 25% of that, which is 150 cc, will remain in the intravascular space. So you have to understand that, because what ends up happening is that medicine will give somebody 250 cc, and none of that volume that has been given remains in the intravascular space. So again, 1000 cc, 25% of it, whatever fluid you give them, however much you give them, 25% of the total volume will be what that's infused remains in the intravascular space. One thing to remember, LR is designed to mimic ECF, and it provides bicarb, which is useful in replacing GI losses. Hyperkalemia, hypercalcemia, hyponatremia. We'll go over the table where it shows you what LR has, what NS has. And you see surgical patients mostly are LR. The reason is because there's always a reason for it. It mimics the ECF. It has a lot of things that will replace the stuff that the surgical patient is missing. Also, in acute pancreatitis, which could be a medical admission, we use LR, because there has been a lot of studies that shows LR actually decreases the inflammation, so we use LR instead of NS. Only 10% of hypotonic fluids. So again, hypotonic fluids is D5 water and half NS. Will expand the intravascular compartment. Therefore, you can use it as a volume expansion. But when you have somebody who's coming in for resuscitation, your first choice of fluids should not be hypotonic fluids. They should be either NS, which is 0.9% NaCl, or LR. Or it could be colloids, which we'll talk about briefly in So this is important, NaCl. So let's talk about extracellular fluid. You see that's, and then you compare it with LR, you see it again, and you see how closely they're related to each other. It has calcium, and this is important. This will answer the question that I asked earlier. When do we prefer NaCl, which is this, over LR? And this would be the answer. So pay attention to the contents of LR and NaCl. And then we can see the 3% sometimes you use in hyponatremia patients that are showing signs of seizure or CNS abnormality. Next slides. So this gives you an idea of compositions of GI secretions. So you have a small intestine. So the reason that we use LR in these type of patients, not so much a stomach, but LR in a small intestine who has, vomiting, non-bilious vomiting, and all that stuff because of the bicarb. So the patient is probably hypokalemic. They're using a lot of bicarb, so you resuscitate them with the LR. That's the closest to the GI secretions. Most of these GI secretions are being replaced by LR. So we talked about the types. So we continue with the types of IV fluids. So we talked about crystal, and now we talk about colloids. So they're confined to intravascular space. What happens is that they draw the fluid into intravascular compartment via oncotic pressure. So they have these carriers that brings in the fluid via the oncotic pressure. So examples that we see used in ICU mostly, albumin 5%, albumin 25%, and dextrans. We usually don't use dextrans, but we use albumin 25%. That's another name for it that we see being used as SPA, salt porous albumin. And use these in patients who are in heart failure. And also the difference between 25% and 5% is that this one, 5%, has a lot of sodium. So if you keep giving this to the patient, you will cause hyponatremia, and you can exacerbate their CHF. So what we end up using is a SPA, which is salt porous albumin. That's 25% albumin. Okay, you hear residents saying SPA. Let's use a SPA. And this is sometimes good because in malnourished patient, their albumin is already low, so you can give them some albumin. There has been a lot of studies that compare crystalloids with colloids, and they really haven't found the benefits one over the other. This is more expensive as well too. So a lot of people tend to use um, crystalloids over colloids, but sometimes it's useful to use these type of other fluids as well too. So pre-op fluid therapy, healthy individuals, maintenance fluids, volume deficit patients, you should be looking at all these signs. Lactic acid, you trend the lactic acid if it's abnormal. You look at the vital signs, urine output, which we'll talk about. You have to know urine output, fluid replacement with crystalloids. So the urine output will get asked that during the rounds, during the morning rounds, during the afternoon rounds. Even on your exam, they ask about how you measure the resuscitation in a patient, and the answer is always urine output. That's the best way to know how well you're resuscitating the patient. Intra fluid. So what happens when the patient goes under anesthesia? It takes care of it blocks the sympathetic and parasympathetic. It causes hypotension. So whoever comes in volume deficit will have this problem as well when they become hypertensive. So we talked about hemodynamic stability, correction of fluid losses. So we have to do that intra-op, pre-op, post-op. Third space edema is another one. So when you have somebody resuscitating, this becomes important in somebody who comes in with trauma. You give them all the fluids that you have, and they have so much bowel edema, for example, or they will have anasarca. Okay, so this bowel edema becomes important, which you will get asked questioned indirectly with intra-abdominal hypertension or abdominal compartment syndrome. Okay, so these are all concepts that should be reviewed. So this is not only a slide on fluids, but it actually can bring in the idea or the concept of abdominal compartment syndrome. Intra-op fluid management. So one thing that I would remember is I would really not remember all these numbers. These are hard to remember. But just remember that you have to give enough fluids for somebody who has an open belly. Every hour, okay, every hour they lose about 500 cc. So you have to take that into the consideration of how long they're in the operating room, how long they're on the table. And when you resuscitate them, resuscitating them, you have to take that into consideration as well too. Post-op fluid therapy. So one thing that I would remember, initial post-op fluids, we put the patient on isotonic solution, so resuscitation again, and then we switch them to D5.5. The reason we do that is because they're MPO, they had a colon surgery, they're MPO, they're going to the catabolism state. So in order to avoid the catabolism state, we want to make him anabolism, so we put him in a D5. D5 provides some calories in addition to the resuscitation fluid, which is a half an S. Another thing that you should remember post-op, don't forget about third space losses. So what you want to do when you're uncertain about adequacy of resuscitation in patients with renal and cardiac dysfunction, you can also do a Swan-Ganz catheter, which you rarely see nowadays. In heart patients, they used to have Swan-Ganz catheter, which gives you pulmonary artery pressure. Now you have these new things in ICU called FlowTrack, which gives you the SVR, which gives you the cardiac output, cardiac index. So those are some of the numbers that you should know when you're resuscitating somebody. So again, adequacy of resuscitation. The best answer on the exam is urine output. Sometimes you can use an ultrasound to look at the IVC. We use that sometimes in the ICU. When we look at the IVC, if it's collapsed IVC, that means that we have room to go give fluids. If it's not collapsed, then we'll know how much we give, how much resuscitation we need to give. Another number that's been debated before is CVP. When you have a patient with central line, you can use a CVP to see how much fluid you give it. But again, they're trying to stay away from using CVP. But that's another number that you can use for your resuscitation therapy. Maintenance fluid. So this is a good question to remember, or good slide to remember. So you want to give much fluids to keep the urine output 0.5 to 1 cc per kilogram per hour. So what that means is that in a 70 kilogram male or female, 0.5 is 35 cc. So they should be making 35 cc an hour. And we always go over that when we're rounding too. We always ask ourselves if the patient is making enough urine, and that gives us an idea of how much fluids they're on or how much fluids they need to be on. Okay. This is another number that you should know. So in a day, when you're trying to put the patients on maintenance fluids, you have to calculate how much they need to be on. So for a day, 100 cc per kilogram per day for the first 10 kilogram, 50 cc per kilogram per day for the second 10 kilogram, and then 20 cc per kilogram per day for each subsequent 10 kilogram. They can give it to you for an hour. So 421 is the rule. I'll give you an example to understand it better. Another way the quickest way to find out how much fluid the patient needs to be on is you look at the kilogram, there are 80 kilograms, and you always add a 40. So they need to we estimate the patient needs to be on 120 cc per kilogram per hour, 120 cc per hour of fluids, okay? So let's do an example. So you have a 60 kilogram female, um, would, so in a 60 kilogram female, per day, they should be receiving 2300. Okay, so 2300 cc of fluid daily. Um, so the way I calculated it is 1000 cc for the first 10 kilograms. So 10 kilogram times 100, and then 500 cc for the next 20 kilograms. Okay, and that would be calculated 10 times 50. And then subsequently for each 10 kilogram, which would be 40 times 20. So they can give it both ways. They can give it per hour or they can give it per day. And then I'll let you guys calculate the 421 and you let me know. So the quickest way, again, 60 kilogram, you add a 40, which is 100. So you should be getting a 100. 421, and you guys calculate and let me know how you would arrive to that answer. If you wanted to know the name of this method, is holiday cigar method. But one thing you remember is pay attention to the question. They might ask you how much fluids the patient needs to be on a daily basis, which can confuse you, or they can ask you per hour, how much the patient needs to be on per hour. Okay. Volume, again, special consideration. Volume excess is common disorder in post-op patients. We give them too much fluids. We tend to give them too much fluids. We leave the patients on fluids and we forget about the fluids. The patient was already started on clear liquid diet after colon surgery. We forget they're taking enough PO and we forget to take fluids off. So volume excess is a common disorder in post-op period. To review, D5.5 again, it increases protein synthesis, prevents protein catabolism. You want the patient to be in anabolism. Okay. Very good. Urine output, again, the number to remember is 0.5 to 1 cc per kilogram. Also, another thing to remember is that a lot of patients talk about their edema on their legs or anosarca. They have edema on their arms or feet or everything else. And you always have to remember mobilization of the preoperative fluid. So you have a lot of fluids, you give them a lot of fluids in the drop, and then that will be in the third space. So it takes about 2 to 3 days after operation for that fluid to move from the third space into intravascular and they pee it out. So you have to tell them, hey, you have to be patient. In about 2 to 3 days, you'll be mobilizing all that fluids that we've given you. Okay. So some common electrolyte disorders, you have sodium. Um, and one important thing is balance maintained by the kidney. Na determines what we talked about, that formula earlier, 2 times the Na. Na determines the plasma osmolality. Okay. Hyponatremia is the most commonly thing seen. May occur in conjunction with hypertonicity, isotonicity, and hypotonicity. Isotonic hyponatremia. Another name for it is pseudohyponatremia. So they're isotonic, but they have hyponatremia. This is very high yield hyperlipidemia and hyperproteinemic state. Myoglobin, for example. can cause that. Somebody with myeloma can have that as well too. Alright, any other hyperproteinemic state can cause pseudohyponatremia. Now, hypertonic hyponatremia. This is another one that's pseudohyponatremia, but it's hypertonic, hyperglycemia. A lot of DKA patients that you might see on medicine rounds is they're hyponatremic, but you have to calculate their corrected sodium and decide what type of fluids to put them on. The most important one that you pay attention to is isovolemic hypotonic hyponatremia, and that is SIADH. Okay? Syndrome of inappropriate ADH is characterized by low plasma osmolality. And just sit down and think about this. Why it causes low plasma osmolality? You are reabsorbing all the water. So less than 280, hyponatremia, right? And low urine output because of the ADH being inappropriate. With a concentrated urine, so usually urine will have a greater osmolality and elevated urine sodium as well too. And clinically they look euvolemic, meaning they're not volume deficit but they're not volume overload. Okay, so there's another one that you should remember: cerebral wasting syndrome. And the way you distinguish those two, they both will have hyponatremia. The low urine output happens in SIADH. The cerebral wasting syndrome, they will have increased urine output. Some of the things that it can cause, and it can be seen in surgical patients too: atelectasis, empyema, pneumothorax, respiratory failure, traumatic brain injury, meningitis, tumors, ectopic ADH secretion. If you guys remember, small cell lung carcinoma can cause ectopic ADH secretion, and that causes SIADH, hyponatremia. The way you treat it is usually, I don't know if you guys remember Conrad Fisher, hyponatremia symptoms usually go neurologic. So they will have mental status changes, they will have seizures. So the way you treat it is that you fix underlying disorders, of course. If you have hypovolemic hyponatremia, you give them NaCl. Sometimes you have psychogenic polydipsia. Um, sorry, you have a lot of water intoxication. You have these psychiatric patients where they're taking a lot of fluids, so you have to fluid restrict them. SIADH, you fluid restrict them. Sometimes you can give them Lasix to get rid of it. One thing to remember from this slide is cerebral pontimyelitis when you correct the sodium very quickly. So serum Na should be increased by no more than 12. I think this number has changed to 8 to 10. Okay, 8 to 10 millimole or milliequivalent in liter in 24 hours. Okay. All right. Hypernatremia, water losses and excessive solutes. The one thing that I would remember is isovolemic DI, diabetes insipidus. We have polyuria, polydipsia in association with hypotonic urine and high plasma osmolality. So you should remember the CDI, cerebral diabetes insipidus versus nephrogenic, and how to differentiate those two. So if you guys remember nephrogenic, if you give him the this the sorry, the nephrogenic, if you stop any offending drugs, so if you give them desmopressin, it doesn't really help because they don't have any central problems. So for nephrogenic, there's a difference between central and nephrogenic. Central, you have to give them desmopressin, they respond to desmopressin. So a lot of times if the question says, patient has been given desmopressin and there's no changes, so that would be nephrogenic. Some of the drugs that could cause nephrogenic is thiazide drugs. Some of the psych meds as well too, like lithium, can cause that. So you stop any offending drugs in nephrogenic, and central you give them desmopressin, they respond. Also, rapid correction of the hyponatremia can also cause cerebroedema. So you have to be careful when you're correcting someone's hyponatremia. Potassium is another major intercellular cation. 90% of it is renally excreted, with the remainder eliminated in stool. EKG manifestation of hypokalemia. So TOPI, T-wave depression, prominent U waves, which everyone knows. Um, so symptoms: mild hyperkalemia is generally asymptomatic. Severe potassium deficiency, you usually have AKG manifestation. So the way you treat it is you give them some potassium tabs, 40 to 100 milliequivalent KCl in patients with intact renal function. That's the key word. Um, a lot of times when you are having somebody with hyperkalemic, they're refractory to the potassium supplements you give them. And you always end up scratching your head. You're like, I've done everything I could. I've replaced that potassium. What is going on? So a lot of times these patients have hypomagnesemia. So what happens is that we check the magnesium and sometimes we give both at the same time. Potassium plus the magnesium at the same time to replace the potassium. So always check your magnesium when you have problems, refractory hyperkalemia to the medication, to the supplements, potassium supplements. Hyperkalemia. Um, Pseudohyperkalemia is a lab abnormality. So the first thing you get, usually the lab will tell you if it's hemolyzed, but most of the time, sometimes you get a hyperkalemia. I usually recheck the lab. So that's usually the answer on the case. Always check the lab because it's usually a lab abnormality. So some of the causes, which we talk about, Addison disease, for example. Let's just go down here. Addison disease, type 4 RTA, renal tuberous acidosis, diabetic nephropathy. So in these type of patients, they have resistance to aldosterone, so therefore that causes hyperkalemia. Aldosterone insufficiency, Addison disease. Decreased aldosterone will increase the K and decrease the Na. They have fever, hypertension, abdominal pain. So Addison disease and type 4 RTA is the high yield from this slide. Increased release from potassium, or potassium from cells. So when you have a tissue injury, trauma after trauma, okay, this people will have injury to the tissue and muscle. So it breaks down, starts breaking down, muscle breaks down. So it releases the potassium into the intravascular space. You get a hyperkalemia. You can have EKG manifested. So some of the symptoms, um, it is GI, nausea, vomiting, diarrhea. Most of the time you will have cardiovascular abnormalities. So on the exam, look for the cardiac abnormalities on the potassium. So much sodium is always CNS, remember that. CNS goes with sodium. Okay. So it starts with high peak T waves. Okay. Some of the things that you should remember, it's not always high peak T waves on AKG manifestation. Sometimes it can tell you widened QRS, flattened P wave, and prolonged PR interval. If you don't catch it soon enough, they will go into a sine wave formation and subsequently a V-fill. Okay. How do you replace it? So how do you fix the problem? Mild hyperkalemia, you can give it furosemide. But the severe hyperkalemia, you get EKG, you have EKG manifestation that we talked about. You give them calcium gluconate. What does calcium gluconate do? Calcium gluconate functions by stabilizing the myocardium. Okay? So there's another one that you can use, calcium gluconate versus calcium chloride. On the exam, they might not ask you, but if you do see this on the rotation, calcium chloride has about 3 times more calcium. So you have to essentialize. You cannot give it through a peripheral IV. Calcium gluconate you can give through a peripheral IV, but because if you give calcium chloride, it causes a peripheral necrosis. You have to have essentialize. So the way you treat hyperkalemia is, first of all, you check EKG. If they have EKG manifestation, usually if they're above 6.5, you give them calcium gluconate, and it has a short half-life. Okay. You give them 1 to 2 amps of sodium bicarb. You give them 1 amp of D50 plus the 10 units of insulin. You can give them beta-2 agonist, albuterol, via nebulizer. We talked about the calcium gluconate. Sodium polystyrene sulfonate. Another name for that is K-Exolate. And that what happens that first of all you have to rule out bowel obstruction, and you give them that. This is more like a long-term type of thing, and they poop the potassium out. Okay, but for acutely you should be doing this if you have a hyperkalemic patient, and you can give them loop diuretics, which we talked about. Okay, that causes hyperkalemia. If it's refractory to the above, you need to dialyze. And if it's severe, then you need to dialyze. Calcium, ionized, protein bound, free, and phosphate bound. Calcium metabolism under the influence of PTH and vitamin D. Hypercalcemia, you have serum calcium less than 8.5 or ionized calcium less than 4.2. Some of the causes is calcium sequestration. So for example, let's talk about blood transfusion. So citrate in the blood, to keep it fresh, is the calcium chelators. So it causes hypocalcemia. Um, Rhabdomyolysis, acute pancreatitis, total thyroidectomy, you can affect the parathyroid as well too. Magnesium depletion. The way magnesium depletion works is that it impairs the PTH secretion and function. Therefore, you will have hypocalcemia. We talked about hypoalbuminemia. 40% of the serum calcium is bound to albumin. So the way you calculate, so this patient comes in with hypoalbuminemia and hypocalcemia. The nurse calls you, they say, oh, there's a critical value of hypocalcemia. But when you look at the hypoalbuminemia, they have low albumin. So the way you correct the calcium is a fall in serum albumin 1 gram per deciliter decreases calcium by approximately 0.8 for every 1 gram of calcium decrease. So in those patients, you correct the calcium, which is 0.8. So what you do is that you give the serum albumin. Let's say the serum albumin of the patient is 2. So you do 4 minus 2, which is 2, and then times it by 0.8, and you plus what you get from that number is 1.6. When you get that number, you add it to the serum calcium of the patient. Most of the time, the corrected calcium is actually good, so you don't need to give extra calcium to the patient. The other thing you should remember is, in that case, sometimes you should remember you can send the ionized calcium that's usually unaffected by albumin level. So that's another case. Symptoms: tetany is a major clinical finding. Chifsack sign, which we talk about, facial muscle spasm elicited by tapping over the branches of facial nerve. Trousseau sign, which is carbopedospasm after occluding arm blood flow. You can have the preoral neck tingling and numbness. Is usually the first sign. Okay, hyperreflexia, QT interval prolongation on EKG is some of the signs of hypercalcemia. The way you treat it, we talked about it. Calcium gluconate, calcium chloride, you check the magnesium, you check the phos. Vitamin D can be added as well too. So remember, calcium chloride contains 3 times more elemental calcium. So it can cause local tissue necrosis with extravasation. So you should be using, if somebody who has a peripheral IV, you should be using calcium gluconate. They usually don't ask about the dosage, but it's good to know that you have 2 choices, so you don't get confused when you don't see on the exam calcium gluconate as an example. You see calcium chloride, it's the same thing. They both will treat hypocalcemia. Hypercalcemia, you have malignancy, hyperparathyroidism, vitamin D intoxication, thiazide diuretics, immobilization is another reason that would have hypercalcemia, PTIHRP, bone metastasis. Good. Now we talk about symptoms. Asymptomatic if the calcium is less than 12. Okay. They're usually symptomatic: altered mental status, nausea, vomiting, ileus, shortened QT interval, increased QRS, kidney stones, dehydration, severe constipation. They become symptomatic when the calcium is greater than 13 or ionized calcium greater than 6. Calcium greater than 15, there's a severe increased risk of heart block and ultimately cardiac arrest. You have to be very careful. So most of the time, in these patients, um, the one that you see in the hospital, usually the hypercalcemia is caused by cancer, some type of cancer. So the treatment it depends on the severity of the symptoms and calcium level. Mild hypercalcemia, we restrict the calcium intake and increase oral hydration. So we talked about mild hypercalcemia, usually around 11, and the patient is asymptomatic. You restrict their calcium intake. If they're on calcium pills, you stop those pills, and you tell them to increase their oral hydration. Hypercalcemic crisis, calcium greater than 13. 13 to 15. You put them on NS, and you have the rate very high, at least 200 cc an hour, and you want their urine output to be 200 to 300 cc an hour in these patients. Sometimes you have them on 500 cc of fluids because you want to get rid of that extra extra calcium. Um, in malignancy, you can use calcitonin, bisphosphonate. So calcitonin inhibits the osteoclast bone resorption. Bisphosphonate inhibits the resorption as well too. Let's go on to the magnesium, intracellular cation, renal excretion retention, not under direct hormonal regulation. So magnesium is a little easier to remember. Hypomagnesemia, it's very commonly seen in critically ill. Bone hunger is another one that you see in sick patients as well. Redeposition of calcium and magnesium bone may cause dramatic hypocalcemia and hypomagnesemia. You see it in diarrhea, malabsorption. You see it in refeeding syndrome, which we'll talk about. You see it in parathyroidectomy. Some of the drugs side effects: loop diuretics, amphotericin B. Hypomagnesemia, you have ultimate tremors, hyperreflexia tetany. Cardiovascular, you can see torsade de pointe, arrhythmias, QT interval prolongation. So you need to treat that. The way you treat it, you IV magnesium sulfate, you can use magnesium oxide. So the way I would remember, magnesium oxide, excessive usage can cause diarrhea. So treatment, be careful with kidney dysfunction as well too. So if you have somebody with acute renal failure, you shouldn't be using magnesium so much, and you have to be careful with the dosage. Usually renal team is on board for these, so you have to be very careful because magnesium can go up and they end up needing dialysis on these patients who are in AKI. Hypermagnesemia, iatrogenic causing renal insufficiency, we talked about it. Some of the laxatives that we use for bowel prep, for colonoscopy, hopefully by this time you've seen some colonoscopies. We give laxatives, magnesium based, magnesium oxide, or magnesium max sulfate we give, or what else do we give? Milk of magnesium. Those have magnesium, so that we have to take into consideration when the patient's renal insufficiency. Magnesium citrate. Um, so some of the symptoms are hypermagnesemia. You have decreased DTR, the deep tendon reflexes, hypotension, EKG abnormality, nausea, vomiting. You stop the exogenous magnesium. You give them calcium gluconate because of the cardiac abnormality. Again, calcium antagonizes the effect of magnesium, and you probably will end up dialyzing. Phosphate is another one. Um, Normal range is about 2.5 to 4.5. Renal excretion, primary intercellular divalent anion, abundant metabolically active cells. Hypophosphatemia, decreased intestinal phosphate absorption, vitamin D, renal phosphate loss, phosphate redistribution. We talked about administration of glucose and treatment of DKA, malnutrition patient, burn patients, refeeding syndrome is another one too. Um, burn patients, we talk about burn patients, they will have increased phosphaturia during fluid mobilization, so they can cause hyperphosphatemia. Refeeding syndrome, early ones, when the patient comes in with bulimia nervosa or really malnourished, you will give them food right away. They end up having diarrhea and everything else, and they lose a lot of phosphate, so they can have hypophosphatemia. Uh, the, the one thing that I would remember for phosphate, it's very important because the symptoms usually cause respiratory muscle dysfunction, diffuse weakness, flaccid paralysis. So this becomes very important because ATP has phosphate. Okay. So when you have an ICU patient, they're intubated, you're trying to wean them off ventilation, ventilation. They're on the machine. You have to monitor the phosphate. If you have hypophosphatemia, it's harder for you to take them off the vent. Not so much on unvented patients, the floor patients, it's important, but in ICU patients, it's very important. And the way you treat it, you give them either Nutrifos, which has the phosphate and it has the sodium, or you can give them potassium phosphate to treat both potassium and the phosphate. Again, if you have hyperkalemia, pay attention because potassium phosphate has phosphate but also has potassium. So you have to be careful in hyperkalemia patient. Hyperphosphatemia, tumor lysis syndrome, impaired renal function. Symptoms usually hypercalcemia and tetany, soft tissue calcification, secondary hyperparathyroidism, diet restriction, hydration, phosphate binders, and dialysis eventually will be treatment for hyperphosphatemia. So, what kind of electrolyte? So, to summarize a little bit, these electrolyte abnormalities. If you guys have to think, what kind of electrolyte abnormality you get in renal failure? So the one that you get is decreased sodium and calcium because of increased potassium and phosphate and magnesium. So phosphate goes up because of the binding calcium to the phosphate. You have decreased calcium. You have increased phos. You have increased K because the kidney cannot get rid of the potassium, and you also have magnesium, increased magnesium. So the next couple of slides, we talk about some of the scenarios. So this is the idea of, the nurses will call you and you have to decide what to do. So the nurse is calling you for patient status post-sigmoidoscopy with a heart failure. On an assessment, when you go see the patient, you know that the patient is dyspneic, crackles are audible on auscultation. What additional signs would you expect to note in patients who you think it's excess fluid volume? So we talked about fluid volume excess, so bounding, increasing pulse rate, elevated blood pressure, distended neck veins, elevated CVP if you have a central line, dysrhythmia. So those are the things that you should take into consideration. A volume, a fluid volume excess is also known as overhydration or fluid overload, and occurs when fluid intake or fluid retention exceeds the fluid needs of the body. It's mostly seen in post-op, okay, patients. So you have cough, dyspnea, crackles, tachypnea, tachycardia, elevated blood pressure, bounding pulse, elevated CVP, weight gain. Also, another one, decreased hematocrit, consciousness. So another thing that you can, connect medicine with this type of fluid volume excess is because of too much pressure, the patients go to AFib. So atrial fibrillation, they have dysrhythmia. We talked about dysrhythmia. So what happens? These patients, you don't pay attention to their fluid, and you get called by the nurses. They say, patient's heart rate is 160, um, irregular, and this is called atrial fibrillation RVR. And you try to correct the causes. First, you go see the patient, you do history and physical exam, um, and then you look at the causes, and then you treat. So some of the causes of atrial fibrillation, one of them could be fluid volume excess. Scenario 2, you're preparing to care for a patient with potassium deficit. You review the patient's record and determine that the patient is at risk for developing the potassium deficit because of which of the situation. Okay? So we talked about potassium deficits, alkalosis, shallow respiration, irritability, so some of the explanation, confusion, drowsiness, weakness, fatigue, irregular rate, thready pulse, nausea, vomiting, ileus. So those are some of the explanations that goes with potassium deficit. Scenario number 3, 43-year-old woman presents with confusion, increased thirst, and bathroom use. Medical history includes bipolar disorder, well controlled on medication. So you have to look at the signs and symptoms. You have to take into the consideration of their drugs. Lithium, demoxycycline, amphotericin cause renal ADH resistance. Um, Pathophysiology. So these drugs will induce the ADH resistance by impairing the water reabsorption in the collecting. So if you guys remember, we have um, um, treatment, we have DI. Remember DI, diabetes insipidus, where some of the medication can cause nephrogenic DI. So treatment, no improvement with desmopressin. So what's that cause? That's by nephrogenic DI, not central DI. So you give them thiazides, you amiloride, replace the free water deficit. Labs, you willing Eulemic hypernatremia, so Na greater than 145, with normal blood glucose, bicarbonate, calcium. So it's a lot of things to think about when you have somebody like this coming to your office and complaining of these symptoms. 6-year-old woman with lethargy and confusion, normal neurologic examination. Serum sodium is 117, serum osm is 250, urine osmolality is 500. What's going on in this patient? Nausea, vomiting, headache, confusion, lethargy. We talked about sodium abnormality. Sodium goes with seizure. Sodium goes with CNS abnormality. Persistently elevated ADH levels, SIADH, causes decreased plasma osmolality, increased urine osmolality. You have uremic, hyponatremia, and decreased serum osmolality. But the urine osmolality is actually increased. Okay. Um, so treatment asymptomatic, you fluid restrict them. If you have moderate symptoms, you can give them hypertonic saline until the sodium becomes 120. The one thing that you should remember again in this type of treatment is cerebral pontine myelinitis. If you corrected more than 8 to 10 milliequivalent per day quicker than this, you have CPM. Some of the causes we talked about: small cell lung cancer, paraneoplastic, CNS infection, multiple sclerosis, MS. Okay, so this is one thing that you should know. Okay, very important. 32-year-old female with history of anorexia, vomiting, feels dizzy. Okay, so vomiting, loss of GI fluids. K, and bicarb. That may increase bicarb, but the potassium goes up. And the increased bicarb level is actually the cause of in the kidney dysfunction. Okay, and the kidney level that will have the effect of bicarb. Okay, um, you give isotonic with potassium supplementation. The way that this is caused is gastroenteritis, anorexia nervosa. All right, let's do two questions. So you have an otherwise healthy 6-year-old man comes into for a health maintenance examination. You do a physical examination, medical history, or are unremarkable. You look at the serum calcium is 11. Okay, you already corrected for serum albumin. And then the two times before that is 10.5 and 11.2. You get a serum phosphorus, which is normal. Alkaline phosphorus is normal. The serum level of parathyroid hormone is a little higher than normal. Okay? We have an idea of what's causing the problem. Okay, it's probably hypoparathyroidism. But the question is not, if you look at the choices, it's not talking about the the cause. It's talking about what you want to do. So if you remember, potassium was 11.5. The patient is asymptomatic, and we talked about that. In an asymptomatic patient around 11s, you can do this: abundant fluid intake. None of this, absolutely not surgical exploration of the neck. Extending cancer and screening, yeah, possibly bone X-ray films, you can do it. But the best answer in these type of questions is maybe one or two answers are correct, but you have to look at the best answer. Abundant fluid intake. Tell them to take more oral hydration. This patient does not need to be admitted. You can send them home. They're asymptomatic. Their level of calcium is around 10 or 11. You can tell them, hey, you need to take more PO by mouth, liquid, to keep yourself hydrated, to avoid kidney stones and constipation. And then you recheck the calcium. Okay, so now you have a 76-year-old man comes in with a fractured midshaft right femur. Um, his pulse is this. He's hypotensive. You put him a large bore IV, so you always have to consider your ABC. Okay, this is another way of doing a question and learning from this. A large bore IV catheter is inserted for fluid and blood infusion. So airway, breathing, and circulation. So circulation, all this stuff, circulation has been addressed, and airway and breathing needs to be addressed as well too. So Foley catheter is inserted. Which of the following best indicates adequate resuscitation? So assume this is a 70-kilo male, normal 70-kilo male. So we talked about urine output 0.5 cc per kilogram per hour. So you need the urine output to be 30 to 40 cc an hour. Remember this, please. A lot of students forget this. This is very high yield. A 50-year-old woman undergoes a sigmoid resection. Intra was 5 hours. Blood loss is estimated at 1.8 liters. She wakes up She's brought to the surgical floor. Her urine output is documented to be decreasing. Over the last 4 hours, it's been decreasing 30, 22, 40, 14, 6 cc. So again, assume that this is a 70-kilogram woman and she should be making 30, 35 cc an hour. Her heart rate is a little high. She's not hypotensive, but her heart rate is tachycardic. This could be because of pain. You don't know. Which of the following is the most appropriate next step in management? So, this is a Kaplan question. It's very important. You should be doing all this stuff. You should irrigate the Foley, make sure the Foley is working. Stay away from this so much. I would not do this right away, okay? Stay away from this. So, you can insert a central line to measure the CVP. You can draw the CBC to get an idea of the anemia and all that stuff if you're thinking of. Irrigate the Foley catheter, make sure that the Foley is working. The answer in this question is actually do a fluid challenge. So you give them 500 cc of IV fluid over 10 minutes and you see if they respond. If they do respond, that means that they need more resuscitation, they need extra fluids. If they don't respond, then you have to think about other things. You can do CVP again, you can do an ultrasound to look at the IVC, see if it's collapsed versus distended. It gives you an idea of, you can send us, we talked about, actually we didn't talk about FENA. So FENA, you can send a urine study. So in urine study you have FENA. If it's less than 1%, you use prerenal. If it's greater than 1%, it's intrarenal or postrenal. So that's another thing that you need to know. So these are my references again. If you have any questions, please approach me or the other residents. Fluids and electrolytes, expect 1 or 2 questions. It has been brought up in the shelf. Comp CK. Just remember all the electro abnormalities, know how they present, clinical manifestations, and know how to treat them. Know the difference between LR and ACL. I said in the beginning, you should go and ask the resident to give you the bags of the LR and ACL. Look at the contents in the back. You look at the FENA, okay? Urine output is another question they ask. So one question they will definitely ask you, and you should know this before you go into the exam, is FENA. It is urine output, so 0.5 to 1 cc per kilogram, and how much to give fluids to a patient. So if you have a 4-2-1 rule, in a 60 kilogram, we talked about, it's almost 100 cc per hour. And the way you do a shortcut is 60 plus the 40. That's just a shortcut. If it's 70, you do 70 plus 40, that's 110. If it's 80, 80 plus 40, which is 120 cc per hour. Okay. Any questions again, you can always email me, alikid@umed.net. You'll have my number. And just good luck. I hope you guys enjoyed the rotation. And ask me any questions that you guys have from me or the residents. Thank you.